like it's amputated, so you're not able to use it. This will just be our pretend injury. Actually, the end of the stump, you wrap in a figure 8, and so I don't have a picture of that right now, but it's sort of like you do this.
The instructions on my part.
Okay, good. She has the instructions on the protocol, a figure 8 wrapping at the end of the stump, but it's like if you look here, I'm wrapping it in a figure 8. So that's how it's wrapped, but I think it's helpful for the scenario to for her not to be able to use her hand, so then you can envision more like what we might do with someone that had an upper extremity amputation. And you know, if you work in a military, like VA hospital or military, you're probably going to see a lot of upper extremity amputations. You would think as a hand therapist I would have seen a lot of upper extremity amputations, but most of the ones I saw were like partial hand amputations. They weren't like arm amputations. So I worked with a guy who lost his thumb, and the doctor transplanted his big toe into a thumb, and he did great. It looked like a thumb after 6 months. And well, it's real. I mean, and I've worked with lots of people that had. I worked with one lady who had the tips of all of her fingers amputated with a boat motor cord. I worked with a nurse that had her ring finger amputated because she got it caught in the helicopter ambulance door. So I've worked with people that have had lots of, I have one guy that had his hand totally severed at the wrist, but it was like a, it was like a radial, it was like a carpentry saw, electric saw, so it was very clean. It was almost like a surgical cut. Sorry.
No, you're good. No, I like it. I just have to shake while I listen.
I feel like shaking off.
I'm learning, but I'm listening.
Okay. Sorry, I thought you were gonna pass out on me.
Oh,
Sorry.
no. I'll let you know.
No, it was a nice clean cut.
Yeah, before your head hits the
Okay,
floor,
Jude.
tell me.
Yeah. Amanda got me.
Alright, hang on.
My boyfriend's grandpa accidentally cut off his first 3 digits with a power saw.
Yeah, it happens. I worked with a pilot that worked for Fruit and the Loom who was making Christmas presents in his garage with a saw, and he ended up, I think, with 2 fingers amputated. But they got replanted, they got sewed back on. I've worked with several people that had implants. All right,
So don't ever work with a saw. We'll just.
well, keep your eyes on it.
Yeah.
That's the trick. Don't get distracted.
My ex-husband cut part of his thumb off, showing me the safe way to cut a potato.
Oh my gosh. All right. Yeah. All right. So, things that you would work with on someone that had an upper extremity amputation is you would do all the range of motion, like goniometry measurements and muscle testing of the parts that are still left, because they end up having to have greater than normal muscle strength and range to be able to operate their prosthesis effectively. So measuring all the joints, range of motion, muscle testing, and giving them exercises to make sure they get greater than normal range of motion and muscle strengthening. So, right away you can give them resistive types of exercises. And if you can imagine, if they're in the military, they're used to that kind of thing. And they're very good about following through on anything you ask them to do. Sometimes they overdo it and their arm swells too much, and so there is a fine line between doing too much. If you're seeing them pretty early post-surgery, then you would take their bandages off. You would do a whirlpool debridement, which means that you have tweezers and you're picking off the dead skin. And generally, we have doctors' approval to take stitches out and that type of thing when that's needed. Hand therapists in the military are treated as first providers, which means they can order x-rays and interpret x-rays and do lots of things that in the civilian world only doctors do. So they have a little bit more free reign of the things that they're able to do therapy-wise. So using the whirlpool, debriding the dead tissue, and knowing how to figure eight wrap the end of the stump. So you want to get the swelling down in the stump, and once you get the swelling down, you can put on a stump shrinker, and it's like a sock that conforms to the stump, and you want a nice like rounded edge to the stump. You don't want like little dog ears of tissue hanging out there. Sometimes they have to do surgical revisions to get the stump smooth enough that a prosthetic device will fit on it. So if you don't get at least a temporary prosthesis on the person that has an amputation within 30 days, cognitively they become one-handed. And so it's really important to get even a temporary prosthesis on their arm as soon as possible. So I would put a universal cuff, and I would have her starting to feed herself and brush her hair and brush her teeth, and if it's a guy, shave, and all those kinds of things with their amputated arm, especially if it's their dominant arm, because I don't want them getting used to using their other arm to do everything one-handed. There's lots of studies that have been done to show that acceptance of the prosthesis is based on getting them in a temporary prosthesis, even if it's just like a universal cuff, so that they can use the arm functionally within the first 30 days. All right. And so if it's a partial hand, if they only lose a couple of fingers or parts of fingers, then I generally put them in like a resting hand. Who has a resting hand splint? With the intrinsic,
I have one right behind
yeah,
you.
if you'll grab the intrinsic plus splint, that's the splint you would want to put them in with partial hand amputation, because you don't want any of their tendons and ligament shortening. Thank you. Yep. So that would be like, so if she still had some fingers, then you would wrap her in this. You wouldn't put straps on it. You wrap her distal proximal, because the swelling swells between the straps, and so you have to ace wrap it on. Let's see. All right, so I'm doing lots of different activities with her, using her arm and hand in sitting, in standing. You might have her do, or him, a lot of the military are male, but I've worked with people that had head injuries in upper extremity amputations, and they had some problems cognitively trying to figure out how to use the prosthesis. But your first 30 days are spent getting the end of her stump in the condition so it's ready to accept a prosthetic device. You work with the orthotist who makes the prosthetic device. You work with the patient on how even before she gets the prosthesis, how the motions that trigger opening and closing the terminal device. So the hook, like if she has a amputation here, how you close the terminal device is you pull your arm back, and how you open it is you extend it forward. So pull your arm back, closes it, open, close, open. So we do lots of activities designed to get familiar with those movements. And you're usually with the prosthetist when they come and put it on the patient. I don't usually teach them how to put it on first thing. I help them put it on, and the first thing I teach them how to do is open and close the terminal device, all right? And then once they learn how to do that, then you have them do it in all kinds of different positions. So standing, sitting, with the arm here, with the arm there, with the arm here, with the arm here, with the arm here, all those different positions, because this is easy. But then if your arm's up here, okay, how do I open and close it, that position. So you don't have any sensation in the prosthetic device, although they're working on prosthesis that has sensory feedback. And probably in your lifetime as a therapist, that will become less expensive so people can actually afford those. But right now, it's like $1 to $2 million to have a prosthetic device that has sensory feedback, all right? So all of this has to be done with vision, and it has to become part of their body, which usually takes about a year and a half for them to accept that this prosthetic device is part of their body, and they can, and by that I mean they can use it without having to look at it. But for the first, 9 months, year and a half, they have to look at their arm while they're using it, because it's not automatic that they know how to do that without looking. Once they get the prosthetic device, you want to work on, we're not concentrating on ADLs for this competency, so preparing a meal, light housekeeping, driving, they might need adaptations to their steering wheel or gear shifts or that type of thing. You might have to modify some of their tasks. They generally would do a job site analysis at their work. So we go to where they work and we look at all the things that they need to do. We may, if they're not able to return to the kind of work that they used to do, if they were a carpenter and they're not going to be able to return to carpentry work, then we would work with a voc rehab counselor to do pre-vocational analysis to see, do they need to go back to college? Do they need to go to some vocational training to be able to retrain for a different kind of job? But we want to get them to the point where they can use their prosthesis for all the things they need to do during any given day. And before they return to work, they have to be able to wear their prosthesis 6 to 8 hours. So the first time you put on prosthesis, you don't want them to wear it more than 10 or 15 minutes, and you have to check for all the red areas. And then so they build up wearing their prosthesis like they would a dynamic splint, 15 minutes a day today, 30 tomorrow, 45 the next day, until they can wear it 6 to 8 hours a day on the job. One of the things with people who have amputations, they tend to get their body in weird positions. So you have to work with them on body mechanics and maintaining symmetry and not getting overusing some parts of their body and getting into weird positions and that type of thing. Let's see. Questions?
For the comp, can we do like pain management or something like with the mirror therapy?
You can. I've seen the mirror in D100, so I'll make
It's right here.
Oh, you got it. Okay, bring that up. Somebody read that before. That's really cool. So I'm going to take this off. Fluidotherapy is really good. Also, once their wound is healed, the fluidotherapy is good to desensitize the end of their stump. It's usually really sensitive, and if they bump it on the table or they bump it on something, it hurts. You have two kinds of sensations with amputations. You have phantom limb pain, which is not necessarily, or phantom limb sensation, which is not necessarily painful, and then you have phantom limb pain. And this mirror therapy, I don't know who originally thought of this, but it actually works pretty well. So you put your non-amputated hand outside of the mirror, and you put your amputated hand inside the device, and then you do whatever movement you do with this hand, you do with both hands. So let's have you make a fist and straighten your fingers, and make a fist, straighten your fingers. And so if you do this sort of on a daily basis, your brain reorganizes its cortical homunculus. You know what the homunculus is? Yeah. And so they've had some really good success with using mirror therapy to reroute the cortical representation in the brain. Like your brain still thinks you have a hand, right? And they have lots of pain in their hand, even though they no longer have a hand, because you still have that sensory representation in your brain. So they found mirror therapy to work really helpful with regaining movement and decreasing phantom limb sensation and phantom limb pain. So you can incorporate that into your therapy. Let's see. Anything else that y'all put on the Google Doc that we
I
have?
think that's obviously I did the education and
Right.
it's like client education, but I think you covered most everything.
Okay. So it's debriding the wound whirlpool and getting a nice stump end so that it can be fitted with the prosthesis. It's doing pre-prosthetic training and then prosthetic training once you get the prosthesis. And you can use fluid therapy for desensitization. You can use mirror therapy for decreasing the phantom limb pain. And it's really oftentimes about retraining them for different jobs than they had before. Yeah.
I was just going to say, we also have